Dr. Amira Mohammed. Many of you know her from her time as a fellow with us at Mount Sinai. Since leaving Mount Sinai, she has become the director of the Critical Care Fellowship Program and the associate director of the Medical Intensive Care Unit as an assistant professor of medicine at Montefiore Einstein. She is an intensivist with a specific interest in acute respiratory distress syndrome and respiratory failure. After completing her med school in Sudan in 2012, she moved to the United States, where she completed her internal medicine residency at Mount Sinai Medical Center in Chicago in 2017, followed by a critical care medicine fellowship with us in Mount Sinai Hospital in 2019, acting as the chief fellow in her final year. Dr. Mohammed research interests include vaccine effectiveness and healthcare disparities. As an intensivist and a clinical educator, her focus has been on residents and fellow education. She contributed to recent changes of the critical care curriculum at Mount Sinai at Montefiore Einstein, with a renewed focus on research and quality improvement. She is part of the ECMO committee, which oversees all the ECMO patients within the healthcare system and has extensively contributed to its recent expansion. Dr. Mohammed is a board certified in internal medicine, critical care medicine. She's a member of the American Thoracic Society, the Society of Critical Care Medicine, and in the Association of Pulmonary and Critical Care Medicine program directors. It's my pleasure to introduce Dr. Mohammed back, and thank you so much for joining us.
Thank you so much, and I'm honored to be back. Thank you all for having me. It's been a while since I saw a lot of the people at Mount Sinai, but I'm happy to be here today, and I'm going to be talking about ECMO, specifically VV ECMO. During this talk, I just want to go over the changes that have been happening over the past few years in terms of ECMO criteria and cannulation. And I did want to go over some research, what the research focus has been and what I think the research focus should shift to. I'd love to get everybody's opinion. I'm going to leave about 10 to 15 minutes at the end for any questions or comments. But if you have anything pressing that you'd like to share, feel free to interrupt me. Okay. I have no disclosures. I'm going to start by giving you guys a case, and I'm going to give a few cases throughout this talk. Each case is actually a case that we have seen here at Montefiore Medical Center, and each case is kind of relevant to the criteria that I'm trying to go over for ECMO cannulation. This is a 37-year-old male who was admitted to an outside hospital with a perforated sigmoid colon, secondary to diverticulitis. He had underwent a Hartmann's procedure at the outside hospital, which was unfortunately complicated by intra-abdominal sepsis. He had multiple abscesses, developed ARDS, and was intubated. We got a call because his P to F ratio was 59 on 100% FiO2 and a PEEP of 14. At the time, his BMI was about 35. And when we get the call for ECMO, the number one question is this patient a candidate for VV ECMO? And just to out of curiosity, based on everything that you see here, and I know you need a lot more information to make the final decision, but do you see any red flags or any reason this patient would not be a candidate for VV ECMO? And I think you can drop it in the chat. I know each institution is different, but I was just curious to see if any of the things that I mentioned would be a contraindication for cannulation at Mount Sinai.
People can put it in the question and answer. I'm not sure with if they're able to use the chat.
Okay.
Raise their hand, and I'm happy to let them speak.
Okay. Well, I'm going to tell you that we ended up cannulating this patient, but this was in 2022. And the reason I'm bringing this patient up is because in 2022, the answer was yes, he ended up being cannulated for VV ECMO. However, in 2015, the answer would have most likely been no. And the main thing that I want to go over is really what changed between 2015 and 2022 to make this patient go from a patient who would never be cannulated or would unlikely to be cannulated to somebody who ended up on VV ECMO. And the main contraindication from everything that I had told you is his BMI, that it was 35. It was a little bit over 35. That would have been the main concern way back then. So why was this a concern? And this was actually also ELSO guidelines. BMI over 35 or class 2 obesity was considered a contraindication for VV ECMO by ELSO. And ELSO is one of the biggest international organizations that overlooks ECMO, both VV and VA. Most of the centers that cannulate for ECMO and have ECMO in their center are certified by ELSO, and they report a lot of their data to ELSO. In return, also has expert recommendations and an expert panel that kind of give recommendation on not only the criteria for ECMO cannulation, but also how to manage patients once they're on ECMO. So a few years ago, this was a contraindication as a BMI over 35 or class 2 obesity was a contraindication for ECMO. And I wanted to dive a little bit into this and figure out why a patient with a high BMI cannot be cannulated for ECMO, should not be cannulated for ECMO. And just to give a little bit of a brief overview of what VV ECMO is, it's essentially used, and I know a lot of you know this, it's essentially a bridge. You're taking over the function of the lungs in VV ECMO, and your hope is that you're going to see a way out. You're either going to see a recovery. So our hope for this patient was that we're going to put them on VV ECMO, and then in a few weeks, months, however long it takes, their lungs are going to recover and they're going to be decannulated and they're going to be fine. The other option is a bridge to transplant. So if this patient goes into respiratory failure and they need a lung transplant, then we would bridge them until we can find them an organ. Or something that we're doing a lot more commonly now that I think a lot of centers are a little bit uncomfortable with is a bridge to a decision. We've actually had at least 3 or 4 in the past couple of months where we just cannulated the patient and then made the decision on what to do afterwards. And we actually have successfully transplanted patients and doing the full transplant evaluation while the patient was on VV ECMO. So you have to kind of have an idea what you're going to end up with. And basically how ECMO works, and I'm going to focus on VV ECMO, you're draining blood through the drainage cannula that's in the vein. In this case, it's in the femoral vein. So it's pulling out blood, and the pump is what's pulling out the blood. So you decide how much blood you want to pull out, or the blood flow, using the pump, and increasing the power of the pump or increasing the RPMs is going to increase the blood flow through the ECMO machine. This blood then goes through the oxygenator. The oxygenator receives blood from the blender, and you can decide anywhere from 21% to 100% how much you want to oxygenate the patient's blood. And this is also where the sweep gas comes in, and the sweep gas is going to decide how much CO2 is removed. So essentially, the deoxygenated blood comes from the femoral vein through the pump, through the oxygenator, and the oxygenator is where both oxygenation and ventilation happen. And then it's returned through a vein as well, and in this case, it's returned through the IJ. This is different from VA ECMO, where the same thing happens. The blood is drained from a vein, so the drainage cannula is in the vein. But in this case, the return cannula is in the artery. So VV ECMO is essentially taking over for the lungs, while VA ECMO is taking over for both the lungs and the heart. So if somebody's hypoxic, what are you using to oxygenate them? Obviously, you can go up on the FiO2. The more FiO2 you give, the more oxygenation you're providing the patient. But also you can go up on the blood flow. So if you oxygenate more blood through the ECMO machine, then you're essentially improving the oxygenation in that patient. But how do you decide how much blood flow to flow through the ECMO machine, or how much flow this patient is going to need? And there's a lot of studies on this, but essentially what we're trying to do is to figure out the cardiac output, and we're trying to oxygenate about 60 to 80% of the cardiac output through the ECMO machine. So for example, if a patient has a cardiac output of about 7 liters and you're oxygenating 5 liters using the ECMO machine, you're oxygenating essentially 80% of their 80% of their blood using the ECMO machine, meaning very little blood is actually going through the diseased lungs, and most likely their saturation is going to be okay. And as you can see here, there's very little deoxygenated blood in the heart because most of the blood is actually flowing through the ECMO machine. As opposed to a patient with a higher cardiac output, let's assume the patient's cardiac output is 12 liters and you're flowing 5 liters on the ECMO machine. So essentially, you're only oxygenating 50% or even less of the patient's blood through the ECMO machine, and the rest of the blood, about 60%, is still flowing through the lungs that are diseased. So even though you're giving 100% FiO2 on the ECMO machine, you're only oxygenating a small percentage of the blood volume or of the cardiac output, and therefore the deoxygenated and the oxygenated blood are going to mix, and the patient's going to end up still being hypoxic. So the amount of blood flow is really important, and the percentage of cardiac output you're oxygenating is really important. So what is the limitation to increasing flow? One of the main limitations is smaller cannula size. And I mention this because this is our favorite cannula here at this center. So what we like to do is a single cannula as opposed to the dual cannulation that I showed you earlier, where the cannula goes in the IJ and it has two ports, one port for drainage and one port for return. This means that you're essentially using a very small diameter in order to cannulate this patient. So what are the positives? The positives is that it's one stick. It's a lot easier to control and less risk of infection. It's more comfortable for the patient than a femoral cannulation, making physical therapy easier. But the biggest drawback is that it's a much smaller cannula. If you put a cannula in the femoral region, cannula in the IJ, you have a lot more space and therefore you can flow a lot more blood. So the most amount of blood you can flow through this one stick cannula is 5.5 liters, which may not be enough in some patients. Another thing that you should know is that there are two lumens go inside the IVC. So there's the drainage port here, where it's pulling out blood. It's going through the ECMO machine, and it's going to come back. The return port has to be exactly around the tricuspid valve for it to go directly into the RV. If you push this a little bit too much into the IVC, then you're not going to oxygenate the blood. So it has to be in the tricuspid valve. We love using this cannula not only because it's one stick, but also because it can be placed at bedside. And usually our CCM fellow actually does a bedside ultrasound and confirms that the ports are where they're supposed to be. So we're able to see the end of the cannula in the IVC. We're able to see that it's not going into the hepatic vein, but also we're able to see that it's not going all the way through the tricuspid and into the right ventricle. So it's quick and easy to place, and we've actually placed it on patients who are completely awake. We Trendelenburg them kind of how we do with the central line, and we'll place it in the ICU without any issues. And after we're done, the patient can immediately participate in physical therapy, and they're immediately able to speak. However, like I said, you're really limiting flow. So if somebody needs high ECMO flow, then this might not be the ideal cannula for them. Other complications for when you increase flow. More hemolysis. So the faster the pump is moving, the more it's going to hemolyze the RBCs, and you're going to see the LDH start going up, the hemoglobin start going down. You may have to cut down on the pump. You might see recirculation depending on what kind of cannulas you have and their placement. The same blood that's being oxygenated, if the suction is too high on the drainage cannula, then it might recirculate the same blood over and over and over without the blood ever making it to the rest of the body. So the patient's going to remain hypoxic while the same blood is going through the ECMO machine. And we call that recirculation. You would know it when you test the blood from the drainage cannula that's coming out of the patient, and you'd find that the PaO2 in that blood is, for example, 200 or 300, meaning that it's very well oxygenated, as opposed to the blood from the patient that is not. And finally, chattering when they're sucked down on the venous system because of an increased suction from the pump, and this would cause the vessel to kind of collapse around the cannula and then release, and you can see a little chattering motion. So all of these are complications when you try to increase the ECMO flow too high. Therefore, you have to keep in mind how much flow this patient is going to need. And the reason I'm mentioning this is because obese patients are known to have a relatively high cardiac output. They have a lot more tissue, and therefore they have a higher cardiac output than patients with normal BMI. So because they have a high cardiac output, most likely they're going to require a higher flow on your ECMO machine. This is similar to some young patients. We see some young patients who have a physiologically high cardiac output, and sometimes we have to maintain them using a higher flow on ECMO. But also there could be pathological increased cardiac output, such as in sepsis, where we see patients with very high cardiac output in sepsis, and therefore we have to temporarily increase the ECMO flow because of that. So because of this concern that patients who are obese may need more flow on the ECMO machine, they were not the best candidates for VV ECMO. This is a study that looked at an estimate of how much blood flow or ECMO flow obese patients would need. So they predicted that a patient whose BMI is less than 40 would probably be okay with 4 to 5 liters per minute, which means that the Avalon catheter, or the single lumen, single stick catheter that I just showed is probably enough. However, once you get to a BMI over 40, so a lot more tissue, a lot more surface area, you're going to need higher flow on the ECMO machine, 5.5 to 6. And this may no longer be enough. So now you may need to do femoral cannulation for these patients. And patients who need over 6 liters may need a third venous cannula in order to maintain 6 liters per minute. And for these patients, we've actually had cases like this where we've had to add a third cannula because 2 was just not enough flow for these patients. And we actually have a patient like this right now in our MICU. We're considering adding a third cannula too. So because of this major limitation, there was concern. There was a special consideration for obese patients. Should they be cannulated, knowing that they have a high cardiac output and they're going to require high flows? But there are other considerations that you have to think about. Something like a pulmonary vascular resistance and pulmonary pressures in these patients are higher than in patients with a normal BMI, meaning that they're more likely to go into RV failure. And here we have patients who've been on VV ECMO for long enough that their RV completely fails, and now we need to switch them to something that supports the right heart a little more, like Protec, which is very dangerous to switch after the patient has become extremely hypoxic. So pretty high risk patients with some right ventricular disease already. They also have a higher resting oxygen consumption because of their increased tissue. They actually consume a lot more oxygen than patients with a normal BMI, meaning that you have to provide a lot more oxygen, and they are more likely to be hypoxic. Some of the other concerns is that even prior to cannulation, we may not be able to optimize their medical management or their conventional management. So in patients with a normal BMI, we usually maximize our management by proning, increasing the PEEP, and making sure that we have really used our ventilator and other devices to the limit before cannulating these patients for VV ECMO. This is very difficult in obese patients, especially morbidly obese patients. They're difficult to prone. We've proned patients who are on ECMO before. So if somebody who's obese and still hypoxic on ECMO, we may not have the option to prone them. First of all, because they may be femorally cannulated, but also because it's physically very difficult to prone patients with a high BMI. I think the highest BMI we've proned here was about 50 something. They have an increased chest wall mass and intra-abdominal pressure, which really affects your PEEP and plateau pressures. So we usually titrate, and we know from multiple studies that we titrate the PEEP according to your driving pressure, trying to maintain your driving pressure around 12 or so. Well, we know that in obese patients, driving pressure is not accurate. It does not correlate to mortality as it does in patients with a normal BMI. So now we don't have a driving pressure to titrate to. What we do in the center is that we do use an esophageal balloon to figure out the ideal PEEP for these patients. But that's not everywhere. So when I get a call from an outside center telling me I've maximized my PEEP, this patient's on a PEEP of 12 and their BMI is 45, I'm not sure that this is the ideal PEEP for this patient. However, I'm not there I don't have an esophageal balloon, and I really don't have much help to estimate what's going to be the best PEEP for this patient, other than plateau, which I'm not sure is going to really correlate with what I'm trying to do. So we may end up cannulating these patients a little bit earlier. And then one of the major concerns that we still have is needle insertion in a patient who's morbidly obese. Even if you get the needle in, the wire might kink. And then finally, even if you cannulate this patient, because of the amount of tissue, or depending on the BMI, there might be some kinking of the cannula and complications later on. So a lot of concerns about cannulating morbidly obese patients made them in a relative contraindication list on ELSO and in our institution. But then more recently, during COVID, this was actually published, and it was well known that morbidly obese patients are not going to be cannulated for VV ECMO. However, more recently, they looked at the data to figure out, is this true? So one of the biggest studies was a study that looked at the ELSO database from 2010 to 2020. And they specifically compared patients with a BMI less than 35 versus patients with a BMI over 35, or patients who are class 2 obesity. They had over 4,700 patients in each group, and they actually matched these patients. So they had a similar degree of illness. They compared mortality, and they found that the patients with a higher BMI actually had a lower mortality. So they were less likely to die if their BMI was over 35. even though they were more likely to get cardiovascular or renal complications or even device-related complications, they were still less likely to die. Not only that, they didn't find a cutoff, meaning that it wasn't that at a certain BMI, these patients were suddenly high in mortality. There was never a high mortality in the higher BMI. So this got people to think, why are we not cannulating these patients if they don't do as bad after cannulation? Some people call this the obesity paradox. You expect these patients to do worse, but in reality, they actually do better. Even though obesity is associated with hypertension, coronary artery disease, diabetes, obstructive sleep apnea, they still somehow do better than their non-obese counterparts with the same disease. So this has been duplicated in multiple studies on ECMO specifically. There was another study looking at the ELSO registry in 2013. There's 2 studies in 2020 looking at class 1 obesity and class 2 obesity. And then there was a study looking at a BMI of 40 and above in 2015. This was an observational study. All of these studies did not show, they showed that patients with a higher BMI either did better or the same as patients with a low BMI. Actually, in some studies, patients with a BMI less than 18, like myself, did worse. So, so this got people thinking, should we really be excluding these patients from the get-go? And this is similar to some other disease states where the obesity paradox has been found, such as cardiovascular disease. There's some studies showing kidney disease. Patients who are obese with kidney disease do better. Sepsis and septic shock, patients who are obese may do better. In these disease states, there is a BMI cutoff in some of them. However, it's not like you expect. The higher the BMI, the worse they do all the time. And then this has also been shown in ARDS in multiple studies. So because of these multiple studies showing that the patients do not do as bad as we expect, this made the ELSO organization change their criteria, changing BMI from a BMI over 35, making it a relative contraindication for a BMI over 40. And right now in our center, it's not really a contraindication. I think the only thing you need to think about is that if you're unable to cannulate the patient, they're not going to be in the study. And that's the biggest barrier. So our biggest barrier is, are we able to cannulate this patient safely? And if we think that we are, and we usually at least give it a shot, then the patient's mortality is probably going to be acceptable or relatively comparable to a patient with a normal BMI. So it's no longer an absolute contraindication in our center. For this specific patient, he was decannulated. He spent about 3 months in the hospital, 2.5 months he was on ECMO. And then he was decannulated, not only decannulated from ECMO, but also he was trached and then decannulated and was discharged home on room air, which we considered a huge success. Next, we have a 38-year-old female with diffuse alveolar hemorrhage. She was admitted with respiratory failure and intubated. Within a few hours, she was at 100%, a PEEP of 16 and a PDAF ratio of 49. We noticed that she had frank red blood being suctioned from her AT tube. She acquired 2 PRBC transfusions since she was intubated about 6 hours prior. So is this patient a candidate for VV ECMO? And obviously the biggest contraindication that we see here is a diffuse alveolar hemorrhage. And why is that a contraindication? So at the time, until now, we anticoagulate patients on VV ECMO. And because a patient who is actively bleeding may not be able to tolerate anticoagulation, this patient would have automatically been excluded for ECMO. However, I just wanted to go over the literature a little bit of why we anticoagulate patients on ECMO. So the ELSO recommendation is unfractionated heparin, a bolus during cannulation, followed by a continuous infusion to maintain an ACT of 180 to 220. This is the ELSO guideline. We use bivalve. The reason we use bivalve, there are many reasons why we use bivalve, but if I had to back up our use of bivalve with a study, this is one of the biggest studies. It showed that bivalve versus heparin decreases the number of circuit-related thrombotic events, but also decreases the volume of blood products administered. Also, bivalve is shorter acting. It's only 25 minutes. So if anything happens, any bleeding or a patient needs to go for any procedure, we can quickly switch it off. So we definitely use bivalve for all of our ECMO patients here, and I think a lot of other centers do as well. But why do these patients need anticoagulation in the first place? The reason is we're concerned about clotting, and specifically we're concerned about 2 parts of the ECMO machine clotting. We're concerned about the oxygenator clotting. And if the oxygenator clots, you're going to notice that your patient's becoming hypoxic. And the post-oxygenator gas, which is usually very high in PaO2. If your patient, you usually try to multiply it by at least 3. So if your patient's on 100%, the minimum PaO2 I expect immediately post-oxygenator should be 300 and above, usually 400. So if you check a post-oxygenator gas and you find that it's 70, then that means your oxygenator is not working, and the most likely reason is clots. Usually we're able to see these clots. We're able to visualize them, but even if not, you can confirm with a post-oxygenator gas. So this is the number one biggest concern. What if our oxygenator clots? We need to keep this patient anticoagulated. The second part of the ECMO machine that can clot is the pump. And you'd notice that your pump clotted when you start increasing your RPMs or increasing the power of the pump and noticing that your blood flow is not increasing. So you need more power for the same blood flow, meaning that your pump is malfunctioning. So these are pictures of the oxygenator clotting and the pump clotting. And when this happens, you unfortunately have to change the circuit. And it's very dangerous, especially in these patients who are completely dependent on the ECMO machine, to stop it and then switch over the circuit. And we've had patients arrest during circuit changes. So it's our least favorite thing to do is changing the circuit on these critically ill patients. That's why we keep them on anticoagulation. But what is the likelihood of them clotting? And I've already mentioned that keeping them on anticoagulation makes them high risk for bleeding. So really, what's the risk of bleeding versus the risk of clotting? So looking at the literature, and this is mostly observational studies, the risk of clotting on VV ECMO ranges anywhere between 10 to 16%. The risk of clotting. The risk of bleeding is between 10 to 29%. Both of these are because of problems with increased coagulopathy because of exposure to the ECMO circuit. Critical illness in itself can cause you to be either hypercoagulable or coagulopathic. And then the non-pulsatile blood flow also increases your risk of both. But which one's higher? Am I more concerned about bleeding or am I more concerned about clotting? So there's actually, there's so many observational studies that are done on this, but this one is one of my favorites. And even though it's a very small study, it's because they compared no anticoagulation whatsoever versus anticoagulation. So they compared 38 versus 36 patients. Of note, the patients who received anticoagulation ended up on ECMO for a longer period of time. So 20 days versus 5 days, which is pretty significant. So they compared survival, and they noticed that the patients who did not receive anticoagulation had a similar survival, so it was not statistically significant. However, no anticoagulation meant less transfusions, and surprisingly, less oxygenator clotting. None of their patients actually required a circuit change, which is pretty surprising. The thing that you need to know is that they actually had a minimum of 4 liters of flow. So remember, if you decrease the flow on the ECMO machine, it increases your risk of clotting. So once they started weaning the patient off and dropped below 4 liters, they would start anticoagulation. But anything above 4 liters, so for 5 continuous days, they kept these patients AC free, and their patients all did okay. In fact, they had a very short duration of ECMO. This really makes you rethink whether or not you need to anticoagulate these patients. And my opinion is that you do probably need to anticoagulate these patients, but I think we're a lot more scared of clotting than we should be. So we now can, if a patient is bleeding or if we're any concern for bleeding, we actually can stop anticoagulations for up to 5 days, as long as we maintain the flow around 4 or above. And for this specific patient, that's what we ended up doing. We ended up flowing VV ECMO without AC. For 4 days. After 4 days, she was decannulated. She was extubated the next day, decannulated 4 days later. She was diagnosed with granulomatosis with polyangiitis. She was discharged in immunosuppression, and she did very, very well. So now we're rethinking our anticoagulation. I think I get very nervous more than 5 days just because I haven't seen it that much in the literature. But I do know that there's a major trial ongoing, a randomized control study that's ongoing in Canada that should be early next year, should be published. That's hopefully going to give us an answer how badly we need anticoagulation in VV ECMO. I have a 37-year-old male. This patient was during the COVID-19 pandemic. So he came in with a COVID-19 pneumonia, ARDS. He was intubated for about 13 days before we got the call. He came from an outside center. He was at 100% and a PEEP of 12. His PDF was at 60, and they were not able to maintain him. So the biggest contraindication here was his number of days intubated. So why is that a contraindication? Why do we not like to cannulate patients who've been intubated for a prolonged period of time? The main reason is the RISP score, the RISP study that was done, I think, in 2013, and it looked at predictors of mortality in ECMO. And one of the major predictors for mortality was mechanical ventilation time prior to ECMO initiation. The longer the patient was on mechanical ventilation prior to cannulation, the higher their mortality was. And that makes sense. The reason it makes sense is the longer time you spend on the ventilator, the higher your chances of barotrauma and value trauma are. And if you spend a long time on the ventilator, and you have enough baro and value trauma, it's unlikely for your lungs to recover after that. That damage may be permanent. So these patients, we were very reluctant to cannulate. However, if you look at the literature, a lot of these studies were done prior to low tidal volume ventilation, or when low tidal volume ventilation and driving pressure were not as popular as they are now. So we really, in these studies, a lot of patients were not on 6 ml per kg or less, and nobody was checking the driving pressures. They were getting high tidal volumes, they were getting high PEEPs, and causing a lot of lung damage. When you look at the literature, the reason that these patients do badly is not only because they have spent a long time on mechanical ventilation, but it's because their lung compliance has dropped significantly. So their lung compliance is dropping because you're causing barotrauma and volume trauma. So this makes us question, what if I'm doing low tidal volume ventilation and low driving pressure? Does being on a ventilator for a long time really decrease my chances of survival? And this is a question that I think we still don't know the answer to. However, we do put it into consideration that it's no longer an absolute contraindication. Not only that, the also guidelines had previously listed 7 days as a relative contraindication. I'm not sure where the 7 days came from, because it's really no study that puts 7 days as the cutoff. But I think 7 days is for some reason considered a prolonged period of time. So for us, we're really pushing the number 7 and trying to cannulate patients if they seem to have been on low tidal volume ventilation and low driving pressure during the time they were on mechanical ventilation. We like to assume that their lung is not as damaged as others, and therefore we don't really have a strict cutoff for a number of days on mechanical ventilation anymore. This specific patient was on the mechanical vent for about 13 days. He ended up being cannulated for ECMO for about 4.5 months. So, and after that, he underwent a lung transplant and he was discharged home. He did very well. He was on oxygen. He's still being followed up regularly. So what I'm trying to say is there's a lot of change in the ECMO criteria over time. As we're getting more and more evidence, as we're doing more and more research, we're changing the type of patients that we're cannulating. So we're no longer considering a high BMI as an immediate no, as AC contraindication, days on mechanical ventilation. And there are many others. We used to reject patients who are on Levophed just because they're on Levophed. We used to reject all immunocompromised patients. Now we really look into the reason they're immunocompromised, and our only absolute contraindication for rejecting a patient for VV ECMO is pre-existing life-limiting comorbid disease. Somebody, for example, with metastatic cancer, something like that would make us say no. Everything else is up for discussion. And we've developed a multidisciplinary team over the years with not just the critical care, but critical care, CT surgery, our lung transplant, our pulmonologist. So when we get a call for VV ECMO, there's a lot of people involved. There's a lot of things that we look at, try to figure out whether this patient is going to do okay or not. And as you can see, the evidence is really limited as to how we can approach these patients. But because the criteria has been loosening over the years, we are seeing an increase in number of calls and an increase in number of cannulations. So Montefiore, I don't know if you guys know where Montefiore is. I didn't know when I was a fellow. I got to know it during my interview for an attending job. But Montefiore is in the Bronx. It's actually the biggest healthcare system in the Bronx. We have multiple hospitals all over the county. And we get referrals from all over not only the Bronx, but we get calls from Jersey, we get calls from Westchester. So we get a lot of ECMO calls, about 50 calls a year, and this is steadily increasing. We have about 100 VV and VA ECMO patients per year. And like I said, we're getting more and more calls and more cannulations every year, to the point where all of these patients used to be in the cardiothoracic ICU, but because of the number of very high volume, now our VV ECMOs are primarily in the medical ICU, our VA ECMOs are in the cardiac ICU. And I think that soon there's going to be an even further shift, because I don't think the cardiac ICU can tolerate the number just yet. We have anywhere between 1 to 6 VV ECMOs in the MICU at any given time, so especially in the winter. So we're trying to kind of study our patient population, figure out what we can do differently. This is not unique to Montefiore. I'm sure you guys are going through the same thing as well, where you see this is a national increase in ECMO use, and you just see an upward trend continuously. If you specifically look at acute respiratory failure as an indication, so this is VV ECMO, you can see that it's nicely been going up over the years. There's a little spike between 2008, 2009, and this is probably because of two things, the H1N1, but also one of the biggest RCTs came out in 2009. So this brings me to does ECMO actually work? I don't think I can give a talk about VV ECMO without talking of whether or not it is beneficial. The short answer is we're not sure, but we think so. But the long answer is there's only 2 RCTs that were ever done on VV ECMO. I think RCTs are the best way for you to figure out whether something decreases mortality and is beneficial or not. But it's going to be very difficult to apply that in VV ECMO, and we're going to go over why. So the 2 RCTs that were done, the Caesar trial in 2009, it was done in the UK, 180 patients, and they divided them into ECMO versus conventional management. They had their tertiary center was their ECMO center, and they would get calls from all the other centers to transfer critically ill patients with ARDS. And if they deemed the patient to be an appropriate candidate, they would randomize, and then they would transfer the patient if the patient was in the ECMO group. So the issue with this study is that they had 22 patients who were randomized to ECMO and were transferred to the tertiary center, but then never were placed on ECMO, either because they improved just by adjusting the ventilator or they died. However, these patients were still analyzed with the ECMO group. Not only that, if you look at their analyses, the ECMO group was more likely to receive steroids. And now we know that steroids are actually helpful in ARDS. So they have a little bit of an extra benefit of their being more likely to get steroids. And finally, the conventional group, we're not sure if they were receiving low tidal volume ventilation. So the recommendation was low tidal volume ventilation, but because they're coming from outside centers, you really don't know what the conventional management entailed. So it's difficult to interpret this study. Nonetheless, their conclusion was that the ECMO group had less mortality and decreased length of stay, which was their secondary outcome. In 2018, a similar RCT was done in Europe, mostly in France, where they looked at 249 patients, ECMO versus conventional management. In this study, they looked at 60-day mortality as their primary outcome. So the issue was that they had a lot of crossover. So they had patients in the conventional management group who continued to be hypoxic, and their SAT was below 80 despite maximizing the conventional management. And they felt like it was unethical to not offer these patients ECMO. So these 8 patients ended up crossing over and going to the ECMO group, and although they were analyzed with the other group. So because of the rate of crossover, and it's 28% crossover for the control patients, it's very difficult to interpret the study, and they found that there's no difference in outcome, but like I said, you have to take it with a grain of salt. And also, they actually had 7 patients who were arrested during cannulation and ended up on VA rather than VV. And these patients, it's a little bit of a different population that I don't think is the population that we're really looking for in this study. So that being said, I don't think we'll ever have a randomized controlled trial that's going to tell us that VV ECMO works for ARDS. Because if I was a patient with severe ARDS and you asked me if I wanted to be in the conventional arm, I will say no, just put me on ECMO. It sounds like it probably works. So it's unethical. I think a lot of us would consider it unethical to perform a randomized control trial with the data that we have. So the best thing that we have right now is the observational studies, some meta-analyses, which looks at the observational studies together with the 2 RCTs that have already been done. And this is one of the biggest meta-analyses that looked at mortality, and it showed that based on the information that we do have, most likely ECMO does decrease 60-day mortality. However, it does increase the risk of bleeding as well, which makes sense because all of our patients are aggressively anticoagulated on ECMO. So because of all these changes in criteria and this evidence that's backing us up, we see a national increase in ECMO use, 433% increase to be exact. However, what's surprising is that we do not see a change in mortality. So we're cannulating all these patients, and our center, the different centers are increasing the number of cannulations, but our mortality remains the same. And this is pretty surprising. It's surprising because, for example, ARDS mortality, because of all the studies and the evidence that's emerging in ARDS, has taken a huge dip. It's decreased significantly since the 1990s. We have low tidal volume ventilation, we have proning, we have so many, the driving pressure, so many things that have been proven to decrease mortality in ARDS. And when we do them, we see that decrease in mortality. We really don't have that much evidence in ECMO. We don't even have evidence that ECMO works, but if we assume that we do, we don't know what to do after the patient is on ECMO and how we decrease mortality on ECMO. Also has reported 47 to 50% mortality of patients on ECMO. This is both VV and VA combined. This study looked at 5-year survival. The 5-year survival was 36%, which is pretty low. They found that after 30 days, the mortality would increase to 73. So if you survive the first 30 days, you are 73% likely to survive at 5 years, meaning the first 30 days are really the most critical. But why are these patients dying? Why are patients on ECMO dying in general? We don't know. So there's actually never been a study looking at why patients on ECMO die. So we tried to look at our internal data to figure out why, once we cannulate patients, why they die. And this is in-hospital mortality. So we ended up looking at from, I believe, 2018 to 2022. We looked at 139 VV ECMO patients and 294 VA ECMO patients. Our mortality was similar, if not a little bit less than the ELSO reported mortality, which is 44% and 55% in VV and VA. We divided the causes of death into 6. We called progressive refractory hemodynamic shock, where we included hemorrhagic and septic shock. So these are patients who are in refractory shock due to hemorrhage or sepsis, despite maximal ECMO support and maximal vasopressor support. There's respiratory failure, patients who are consistently hypoxic despite maximal ECMO support and ventilator support. There's cardiogenic shock. These patients are on mechanical support and inotropic support, and they continue to die. Neurologic withdrawal of care or neurologic death, which is a patient with a devastating neurologic injury, such as a hemorrhagic stroke, anoxic brain injury, or ischemic stroke, causing either you to withdraw the ventilator or the patient to die of it. Comorbid withdrawal of care, which is the development or the existence of terminal illness, organ failure, or a serious medical condition that would have decreased the quality of life of the patient significantly, leading to a withdrawal decision from the family. And finally, equipment failure. And in equipment failure, we mean the cannula broke, the ECMO machine stopped working. That happened twice, thankfully, not more than that. So when we looked at that, and we had two of our physicians review each and every chart that died in the hospital and pick a cause of death, and we confirmed these findings. So it's a 2-reviewer process. We found out, surprisingly, that most of our patients ended up dying because of either comorbid withdrawal of care or progressive hemodynamic shock. Are just some things that I found interesting was our average time on ECMO was 11 days, and we consulted palliative care about 50% of the time at around 8 days, a little bit over a week. But what's really surprising is that these patients cannulated for VV and VA are cannulated for respiratory failure or cardiogenic shock, but they never die of those things. They end up dying because of comorbid withdrawal of care or progressive hemodynamic shock. So why is this important? And I think we have to think about the attributable cause. So just to give you an idea, so let's assume these are the patients with respiratory failure. And these patients are, let's assume, are probably going to die of severe respiratory failure. We put them on VV ECMO, and we're able to save a few, but we still have about 45 to 50% of the patients dying. What is our goal with all these studies? I went over so many studies. We're analyzing VV ECMO and trying to decrease the risk of mortality. And we're trying to decrease the risk of mortality, let's say from 45 to 50. Ideally, we'd like it to be about 10% death, at most 20% death. But what are we focusing on? We're focusing on improving oxygenation. At least this is what we're focusing on here in the center and all of the studies that are coming out. We're really looking at what anticoagulation to use to stop the oxygenator from clotting. We're looking at what is the ideal flow. We're looking at blood transfusion, how to improve oxygen delivery. We're looking at all these things to try to improve the oxygenation in patients on VV ECMO. But looking at the causes of death, this is not why they're dying. They're not dying because they're hypoxic. So even if we have this excellent therapy that's going to improve oxygenation on VV ECMO, it's probably only going to decrease the risk of death by about 5%, because only 5% of patients are dying because of severe hypoxia on VV ECMO. The rest are dying because of other comorbidities. They're dying because of refractory hemodynamic shock. Not only that, if you're trying to improve mortality by improving oxygenation, you're going to need a massive sample size in order to show that decrease by 5%, because most patients are not suffering from, are not dying from hypoxia once they're on VV ECMO. So this is really important information. So now this brings us to think is, okay, well, the people who are not dying from respiratory failure and not dying from severe hypoxia, should they have even been cannulated in the first place? If they're not dying from hypoxia, I fixed their hypoxia and they're still dead, then maybe they shouldn't have been cannulated. So this leads me to my last point, which is our current research focus. We're focusing on whether ECMO works. We're focusing on improving oxygen delivery. We're focusing on the type of cannulas that we need to use, the ECMO flow versus cardiac output. And we're focusing on really how to improve the oxygenation of patients on VV ECMO, when we really should be looking at, are these patients really dying? And you know, what I showed is our internal data, which is obviously take it with a grain of salt. But we're actually working with Mount Sinai as well to do a multi-center analysis of causes of death in 6 centers. So hopefully we're going to publish that soon. But we really need to look at why are patients dying after being cannulated for ECMO. We really need to look at palliative consultation. How early should it happen? How important it is. And we really need to look at our criteria for cannulation. Sure, we're cannulating a lot more, but are we cannulating the right patients? Are we cannulating patients and then they're going to end up dying anyway, regardless? So in summary, the ECMO criteria has changed significantly over time and continues to change based on emerging evidence. The mortality remains high, and we still need a lot of research in order to standardize the approach for ECMO in different institutions. And that's it. Thank you.
Amira, thank you. That was a great talk and very, very thorough. I gave a bunch of people permission to talk. So it looks like Sam has a question. I'm sure, being our VV ECMO extraordinaire in the MICU, I'll hand it over to Sam.
Yeah, and I'm just excited to say hi to Amira. You know, how you doing?
Hi, Dr. Alko. Very nice to see you.
Very nice seeing you. Listen, excellent talk, excellent talk. But again, I think you touched on a lot of very important, points, and I think patient selection is key, just in terms of who we offer, ECMO to, right? And I think that's where we all struggle, seeing who the ideal candidate, will be. I think you and I are in the same camp, we know that ECMO does work, but for the right people, the question is who to do it, when to do it, and I think that's where we'll see improved outcomes. I think that gunshot approach, yes, giving to everybody, doesn't help. And number 2 also is the patient management, right? And I think that's where, I think the shift in, the ECMO now being in more the medical ICUs, versus just hanging out with the surgical, because I think there's a lot of focus on the machine, the oxygenation, as opposed to treating the patient itself. And if you look at the ARDS literature from the past, people never really died of hypoxemia itself, they died of multiple organ failure, right? And so I think focusing on like the lower tidal volumes, focusing on appropriate PEEP, patient management in general, I think is what's more helpful. So hopefully, with that focus, now more on the medical aspects, things might change in terms of outcomes, right? But again, those are just 2 early comments, and again, I'll give the floor to other people to make some comments. But again, that was a very good lecture.
Thank you, Dr. Alko.
Okay.
I opened up the chat to a bunch of faculty. If they want to ask questions, they're able. If anyone else wants to ask questions, please raise your hand and I can give you the ability to ask questions.
The other comment I had, though, when someone's raising their hand, is how many are you seeing now? Because right now I've seen after COVID, our numbers have, dipped, and I call all my friends in Colombia, North Shore, everybody says they're not seeing any VV ECMOs that much anymore. And I believe with, COVID, we are all better at managing ARDS, is what we try and use it to explain. Are you still seeing high numbers of people on ECMO now?
So we're definitely less than the COVID times, but we always have at least one patient VV ECMO in the unit. I think our team here is pretty aggressive. Most of our patients are actually newly discovered ILDs, and we do transplant evaluation while they are on ECMO, and then it's kind of a bridge to a decision. But we do sometimes see ARDS. We had a couple of asthma and viral infections over the winter. So definitely less than 2020 and 2021, but we are seeing a decent amount still. I think, there was a time where we had 6 patients on VV ECMO continuously on and off for a few months in 2021, but definitely nothing like that 2022 or now.
Yeah, because we've seen the same here. Here's a dip in numbers.
Yeah.
Amira.
Dr. Adele. Hi.
Congratulations on your accomplishment. We are very proud.
Thank you. Thank you very much. It's very, very nice to hear your voice.
Nice to see your accomplishment, and thank you for coming and presenting, and congratulations on the program directorship. I have a question. First, I'm trying to open my camera. I can't, but anyway, regarding the Avalon catheter, and it sounds like you exclusively use it. Do you
Hello?
We lost Adele.
Oh.
Okay, I'm back. Sorry.
Yeah.
Now you can see me.
Hi.
Avalon catheter, and what's your experience? And you mentioned the limitations in terms of the flow. And would you go back when you need more flow to do 2 separate catheter, 1 and 2 separate veins? Just share your experience. That would be very helpful.
We actually just add a 3rd cannula, and we've had that. I would say over 90% of the time, the Avalon is enough. But there are these patients. The one in the medical ICU right now, his cardiac output is definitely very high. So what we would do in this case, he has an Avalon catheter. We're at 5.3 liters. We can't increase it, so we would add a 3rd femoral line. That would be a drainage cannula, in order to maximize our flow that way. So it would be VVV. So we have done that a few times in patients where flow is limited.
So you end up, what percentage of time you end up using the 3rd cannula, which is?
I would say it would happen once or twice a year at most.
So it's not as common.
Yeah, definitely not as common.
So you recommend using it as the initial placement?
For Avalon catheters, we've become very comfortable with them. We found that the risk of complications is a lot less. They don't kink as frequently, especially if compared with the femoral. They're easier to place, and the fact that initially we were nervous about the ports being in the exact spots with the tricuspid valve and the IVC, but now that we're using POCUS at bedside, we've never had an issue. We usually confirm using the POCUS, and the Avalon catheter goes in fine. So that's our go-to. I would say nearly 100% of the time we use an Avalon catheter.
And has the technique of insertion any different than the dialysis catheter, for example? You need to have lower angle a little bit so it doesn't kink?
No, we actually do it the same way. We usually do a little bit steeper than, I think for the initial insertion, put it at 90 degrees. This is why I would go a little bit steeper, but after the dilation, it's pretty much the same.
Okay, so no change in the routine dialysis catheter.
Yeah, so but you guys don't cannulate yourselves though, right?
No, we have had a few of our fellows who are interested cannulate with their surgeons, but usually we have to do the POCUS and the
or TE to help. Yeah. Do you use the Protect at all? Because I don't know, with the Avalon catheter, as you said, it's very temperamental, Adele. So yeah, we don't really use. I mean, if we have to use one like that, we'll do more the Crescent. I think the Crescent is a bit longer, so it gives a better flow, from the SBC, IVC, I think. But the Protect, I think is the best of the lot. I think there's 0 recirculation, so I think it's the ideal cannula, right? So we're trying to use more of that now.
I love the Protect. The only issue is that it can't be placed at bedside.
Mm,
And by the time first of all, a lot of our patients, we cannulate in their centers so that the cardiac surgeon cannulates whoever the patient is at the other hospital. So that can't be a PROTEC.
yeah.
And then patients who we cannulate in-house, they're usually extremely hypoxic and dangerous to even move to the operating room in order to place the PROTEC. But we have switched patients. So after we
Yeah.
cannulate an Avalon and maintain them for a few days, if we feel like their RV cannot handle it, then we take them to the OR and switch them over to PROTEC. But PROTEC from the get-go, we haven't done that frequently.
Yeah, and again, it has to be done on the fluoro, yes, you
Yeah.
know,
Yeah.
but like in those cases, what we'll do like a fem, you know, if again, it's a transplant patient who is very hypoxic for the fem, and then you can convert easily to a PROTEC, you know,
Exactly.
yeah.
Yeah.
Thank you, Amir.
Thank you.
I have
Thank you, Amir.
a question from one of my fellows. Are you guys using esophageal balloons for optimal PEEP? And are you proning people on PEEP? On ECMO, sorry.
Yeah, we use esophageal balloons for morbidly obese patients nearly universally, and that's how we titrate the PEEP, because we use driving pressure for everybody else. But once somebody's morbidly obese, we use esophageal balloons pretty consistently. This has honestly not happened in a while, but we have prone patients on VV ECMO if they're severely hypoxic. The only thing is that, you know, if a patient is hypoxic 3 weeks into their course, there's no benefit to proning. But if it's pretty early on, then yes.
Yeah, and yeah, I'm still not sold on the whole proning with ECMO patient thing, right? I just feel it's a lot, right? You know, but I know some centers have done it very successfully, you know, but I still trying to understand the whole benefit, you know, it confers.
Mm-hmm.
Okay, Amira, I think we're out of time. Thank you so much for
Thank
giving
you.
us this talk today, and we will see you soon.
Thank you.
Congratulations
Thank you for
again.
having me.
Amir, nice
Bye.
seeing you.